morning. Today I will be talking on intramedullary rods and onlay grafting in cases of Crawford type 4 TPT. We know that Crawford described 4 types, of which the fourth was the worst, with atrophic ends, with or without pseudarthrosis of the fibula. Conventional treatment has been dual onlay bone grafting or McFarland's bypass grafting in the earlier types, which is sclerotic. Sofield's fragmentation technique, intramedullary rods with bone grafts with stimulation, or with dual onlay graft, which was actually popularized by Benjamin Joseph, and rarely amputation. Baker published in 1992 that union rates after different procedures vary a lot, but 91% procedures without an intramedullary rod failed to unite. And Onishi, in his paper in 2005, studied 73 patients with various types of treatment and found that Ilizarov and vascularized fibular graft were the most acceptable methods for the best primary union rates. However, intramedullary nailing with bone graft was only 6 of these. Benjamin Joseph, in his work, which was published in 2000, showed us that the microvascular free fibular transfer in his series had a 65% primary union rate. Ilizarov had 95%. But his method of intramedullary nail with bone graft had a 88% union rate, which was quite comparable. His series of 26 patients over 13 years, of which 13 patients were younger than 3 years old, where he excised the pseudarthrosis completely, did a cortical onlay bone graft, and an intramedullary rod, either a rush nail or a Sheffield rod. And they found that the average time to union was about 4 months, plus or minus 2 months. And in younger age, they found that actually the shortening rates were less and associated growth abnormalities were quite infrequent. Less than 3 years, they had a 92% union rate. Between 3 and 12, 70%, 21%, and about 12, it was 66%. And he concluded there is no justification in deferring surgery to an older age of about more than 4 years. And in young children, they recommended excision, cortical bone grafting, and intramedullary rod. And Ilizarov was quite cumbersome and difficult to do in this age group. And the EPOS studies earlier, which said that results are poor in less than 3, are really not valid. Matthew Dobbs also published in 2004 about the long-term results, and he found that the initial consolidation happened in 18 of 21 patients. However, refracture was seen in 12 patients, 5 were treated closed, 5 needed additional surgery, and 2 needed amputation. 10 patients of 18 had valgus in the knee, valgus in the ankle. 11 had a limb length discrepancy of more than 2 centimeters, which needed treatment. And 5 needed amputation because of various reasons. It was quite high. In the longer follow-up from Benjamin Joseph and Hitesh Shah, they found at skeletal maturity, in age of 18, 9 of 11 achieved primary union after the index surgery. 2 needed additional surgery. 10 out of 11 had persistent fibular pseudarthrosis, but it did not matter in function or the union of the tibia. 10 children needed various additional procedures, totally 21 procedures. There were minor problems of ankle valgus, a little bowing of the tibia, and about 2.5 centimeter shortening. But the ankle did become stiff in a large number of patients, but there was no pain or donor side morbidity. The technique involves resection of the hematomatous tissue, passage of intramedullary rod retrograde fashion, docking of the fragments acutely, and then opposite tibia cortical onlay grafts, which were stabilized or not stabilized, and protection for a long period of time. Based on this technique, the precursor of this was the Williams rod, which was a smooth pin inset with a threaded introducer across the ankle, and then it was withdrawn so that it stabilized. And this was the Williams rod with that threaded introducer, which has now become historical. But Johnson studied the long-term results of Williams rod in type 4 CPT. And they divided the surgery into 3 types, A, B, and C, where they resected both bones, tibia and fibula, or just the tibia, and where fibula was not treated. They concluded that primary union is good in 82% cases of intramedullary rod, but they found that if the fibula is not fixed, they had poorer results. So they recommended fixation of the fibular pseudarthrosis too, which is contrary to what Dr. Joseph said. A few cases of my own to highlight the results. This is a 3.5-year-old with a CPT treated with antegrade rush nail and cortical grafts. I stabilized them with screws. And this is over a period of 4 months, how they healed up. But as the child grew older at 1.5 years, you can see that nail has become short and there is some anterior bowing and the screw has become loose, which needed subsequent revision. Another example of a 6-year-old untreated CPT with fibular CPT. This was classical Joseph style where we did a retrograde nailing and a cortical graft, which I stabilized with a screw. This went on to excellent healing. In 5 months, I revised it to an antegrade rush nail, thinking that I should free the ankle so that there is no stiffness. But you can see that gradually distally it started bowing again. So I had to revise it and I used the FD rod, this time a telescopic nail. And that has worked quite well and he's consolidated well and the rod is opening up nicely. A 7-year-old, 3 previous surgeries, a trans ankle rod which has broken. We revised it with a rush nail and cortical graft which was stabilized with screws. And you can see it has consolidated very well in 6 months and the rod continues to be in situ to protect the segment. Failed elastic nailing for CPT, somebody had tried, again type 4. Now I've decided that I'll do a more rotationally stable fixation. So I put a telescopic nail of the FD variety retrograde, trans ankle and a cortical graft. And that is how it has united over a period of time. Another case where a broken rod is seen, a similar kind of a surgery, a retrograde FD rod with cortical onlay. And this is another case where somebody had done a live vascular fibula with broken rod inside. We revised it to a FD rod trans ankle and cortical bone grafts, and that has consolidated quite nicely. This is another example where now I have started doing primary FD rod with cortical onlay bone grafts, and that has healed so well in about 4.5 months. This is a 4-year follow-up where the nails failed to telescope. Actually, they migrated inside, but they have stabilized the segment pretty well and there's hardly any shortening. To summarize, old techniques are really still gold. Thorough resection of hematomatous tissue, especially posterior periosteum, is important. A stable intramedullary fixation will give you primary union. You need to pass the rod across the ankle or use a fascia duval telescopic nail. Cortical onlay works very well. I prefer fixing the graft with screws. Fibula may or may not be treated. Rod may need revision, but needs to be there till maturity and even beyond. Additional protection as needed. And nowadays, people recommend bisphosphonates preoperatively so that the graft has lesser osteoclastic activity. Thank you very much for your kind attention.